Great. Thank you for the opportunity to talk today. So a lot of the same principles that have already been discussed are going to apply during endoscopy, and I have nothing to disclose. So just to refocus on a couple central tenets, and you've heard these kind of over and over again, but how do they apply to endoscopy? So cut, coag, and blend. You can see that duty cycle represented on the left side of a pure cut. It's 100% on, and it turns out to be about 1,400 volts. And this is a little bit of an older study, but just to show you, when you turn that duty cycle down where it's just firing about 6% of the time, it's about 9,000 volts. And this is why we all keep emphasizing that that high voltage coag mode is the most dangerous mode. There's just lots of opportunity for leakage of this energy. The other thing that's very important, just as it is in open and laparoscopic, is this idea of current density. And so when you're trying to do that polypectomy, you really want to focus that current density around a small area to generate a high current density. If you think of when you're performing a polypectomy and you're trying to transect a lot of tissue, you end up using a lot of energy for a long period of time. And the longer that you use that large amount of energy, the higher risk you are for complications that we're going to discuss in a second. So what specific procedures can we go into? And I'll touch on bleeding a little bit. A lot has changed over the last few years with regard to the management of endoscopic bleeding. The clips that are coming out now are completely rotatable. They're much easier to apply and they're much more effective. And so I personally have never actually used this device to stop endoscopic bleeding. Instead, I'm injecting and clipping. But just to be thorough, we do need to talk about this gold probe, which is a bipolar device. And one of the important techniques of applying this device is really to compress that bleeding vessel. You compress it and then you activate it. And then the other important thing about stopping bleeding in the GI tract is that you really need to be using two different modalities. So if you're going to use this device, that's great. Make sure you do an injection afterward, or make sure you do clipping afterward. But that is really your most effective way of stopping bleeding. You need to be doing two different modalities to stop it. For those of you who are still using this gold probe, or this is your only opportunity in the middle of the night, there are some basic guidelines that are available as far as the settings, because it can get a little confusing, and I'm not going to go through this in detail, but depending on what kind of lesion you're going after with this gold probe, there are guidance as to how you should set that device up. So now let's kind of move back to polypectomy, something more common that hopefully we're all doing, and there are multiple different devices that you can use to remove the polyps. Not too long ago, we used to think that we're going to use this biopsy forceps. We're going to grab these polyps and activate the biopsy forceps, fire a little energy. Maybe that'll get better removal of this adenomatous tissue, and that actually proved to be false. You increased your risk of complications and you're removing less tissue by trying to trust the energy as you're using your biopsy forceps. And so now multiple studies have shown that if you want to completely remove the tissue, you really want to be using a snare. Whether it's a cold snare or a hot snare, you're going to get a better resection of these polyps. When you're considering using energy, and this is usually for polyps that are greater than about a centimeter in size, you're going to consider using a coag mode or a cut and blend mode, just as we've discussed. And as you can predict, when you use that higher voltage coag mode, you're going to have a higher risk for complications. You're going to get a greater depth of mucosal injury. This was on pathology. You're going to get worse quality pathology because you're ablating some of the tissue. You're not going to be able to really see that defined edge of the adenoma and ensure that you've completely taken it out. I think surprising to a lot of us was this idea that there is a similar incidence of bleeding. And this really goes back to the fact that it was unfortunate that the modes were named as such. The coag mode was named coag, and it really should be a high voltage versus a low voltage mode. The interesting thing about bleeding when you're using these two different modes is that if you use a cut or a blended mode, you're more likely to see the bleeding right there. If you're going to use a coag mode to transect some of these polyps, then you're more likely to see a delayed bleed in 2 to 8 days. And this is kind of like dealer's choice. In my opinion, I would prefer to actually see the bleeding there and clip it before I'm done with the case than seeing the patient bounce back with a lower GI bleed 2 to 8 days later. But the overall incidence of bleeding is the same. It is important to remember, especially for the test, that that cut mode is going to result in a bleed at the time of the procedure, whereas the coag mode is going to result in a delayed bleed. And then finally, there's no real difference in the perforation rates, whatever mode you use. What are some other techniques, some actual handheld techniques you can use to avoid injury? And I think these are pretty straightforward. So lifting the mucosa with your injections of methylene blue and whatnot to really get separation from the mucosa from the underlying muscle. You don't want to create a full thickness injury, and that is one way to help protect it and give yourself a nice cushion to come through it. You want to tense up the mucosa, again, avoiding injury to the muscular area. And one thing I'll get into shortly is that you don't want to too courageously tense up the mucosa and result in energy accidentally transferring to the other side of the bowel, which I'll show you in just a minute. So where do these injuries occur? Obviously, they're going to occur right at the base of the polyp. If you don't provide that nice saline lift for a large flat lesion, you grab a lot of tissue, you can actually make a full thickness injury, and that can be a bad deal for the patient. In addition, what we found out, and this will be coming out in the next few months in surgical endoscopy, is that energy actually transfers within the scope itself, and it's going into that camera cord and it can be zapping the patient outside of your view, and you won't even know it happens until the patient comes back 3 to 5 days later with a post-polypectomy syndrome, or, God forbid, with delayed bleeding or even a perforation. And then finally, there's this opportunity for a direct application for energy if you tense it up too close to the opposing side of the bowel wall to go right into the bowel and create another injury. So this is this idea of antenna coupling that's been talked about, capacitive coupling. It's the idea that you have an antenna broadcasting energy, and just like in your car, you can pick that energy up. In the operating room, we've kind of demonstrated this a few times with laparoscopy, and it's really that long, active electrode, and especially the cords when they're in close proximity and aligned in parallel, that you're going to start transferring a lot of energy. How much is a lot of energy? I know you already saw this video, but it is very impressive to see that you can actually create burns. The active electrode is not touching this laparoscopic camera. The cords are just lying next to each other, and you're getting a ton of energy transfer straight to the tissue from your camera, and you're not even going to see this. This is going to happen to the bowel that camera just may be sitting on while you're trying to do your cholecystectomy. And what we found through studies with this is that really it is the close parallel alignment of the cords. So then as we were thinking about it, when you do endoscopy, your energy device is forced in parallel for the vast majority of the length. So this is essentially the perfect setup for this capacitive antenna coupling to happen. And that's also what we ended up finding. And so there's just a snare that I've kind of retracted into the working channel there just so you can see. And as you activate the energy device, you're going to see sparks going directly from the camera channel to tissue. This is that idea of antenna coupling and capacitive coupling during endoscopy. And this just kind of confirms it on thermal imaging. You can see it jumping up 98, 100 degrees. So definitely high enough to cause significant tissue injury. So we looked at the different ports in the channel. We didn't really know what was going to kind of transfer or accept most energy, and it turns out that it is that camera channel, and it's probably because it's the largest cable within the scope. All of the pulleys and other devices used to manipulate it aren't in continuous parallel alignment, so really it's your camera channel that's at highest risk. We looked at different devices and activating them within the channel just to kind of see what is the highest risk device to use, and it's that biopsy forceps. And we activated on 60 watts coag so we could see what was going on, and it increased our tissue temperatures 25 degrees. So that's, again, well over the threshold of 60 degrees. You can be causing significant injury. And this is not the tip of the biopsy forceps causing this burn, essentially. This is from the tip of that camera lens on that endoscope, just like I showed, going straight to the bowel. Again, you wouldn't even see it. It's going to be off your screen. Just to compare apples to apples, we just looked at your standard snares at similar settings using older and newer generators. And the big significant thing I want to emphasize here is just as technology improves and as we've gotten generators that will modulate the output and reduce it as your tissue impedance changes, we can see that we have less accidental stray energy transfer. And then one final mechanism during standard polypectomy, so this idea of direct application, so the polyp, the energy can jump straight from the tip of the polyp to the opposing side of the bowel, and this can create really high energies, greater than 90 degrees Celsius. Obviously, you can create a very bad injury when you're trying to wiggle that polyp so that it'll pop off. You got to be very cognizant of not allowing it to get very close to the opposite side of the bowel. So just a few kind of reviews of standard endoscopy, and then we'll do a couple advanced procedures and be all done. So bleeding, again, you always want to apply 2 agents. That's your most effective way to stop GI bleeds: clipping, injection, gold probe if you like. And if you do use a gold probe, you want to compress the vessel. Polypectomy, you're really focusing on maximizing your current density on these larger lesions that you're going to use energy with, and you want to combine it with lifting or tenting of the mucosa to get that good separation from the underlying muscle. And then when you're wiggling to try and get that to go all the way through and to transect it, you really want to make sure you avoid touching the opposing wall of the bowel. So the argon device is a very good device, very effective, provides a nice superficial burn if you're treating GAVE, for example, in the stomach. But it has its own risks, so it's pumping a lot of argon gas. You can cause perforations if you're not actively suctioning or using short bursts, and so that is a unique avenue that you really need to pay attention to when you're using the APC device, constantly suctioning and clearing that argon out. It is also a very high voltage device, and so all the complications we just discussed with coag devices, you can definitely have happen when you're using the APC, especially if you're sitting there kind of firing away over this big area of vascular ectasia. There is a bipolar device that many of us have seen for the treatment of Barrett's. This is a low voltage device, so from a grand global energy perspective, it is actually relatively low risk. Most of these complications are probably related to the direct tissue effect that you're causing, the ablations causing namely strictures. There are rare reports of bleeding and perforation as well, but overall a relatively safe device. And then there are your more advanced procedures. So we're taking out bigger and bigger lesions from all over the place, and all of these use energy. And we know that the rate of complications in all endoscopy is higher when you're using energy, and the more energy used, the higher the risk of complications. And so we need to be very cognizant about all these fancy new devices that we're trying to use. We don't necessarily know the safety profiles of taking out these massive lesions with energy. What kind of energy-related complications are we going to be seeing? It's hard to say, but what we do know is that we need to be using the minimum settings for the safe procedure, really focusing on your tissue effect and not just generically setting it to 30-30 or the equivalents in the endoscopy suite. You got to use your adjunctive techniques that we just discussed. It seems that some of the newer generators that monitor impedance are more protective. And then finally, suction aggressively during argon use. This is really a very, very new and poorly studied field. It's a great opportunity for kind of research to help us better understand, especially as we, like I said, resect bigger and bigger lesions. We really need to know where our energy is traveling in the patient. That's it.